Hi all, welcome to Physio Exam Buddy. This video is on circulatory shock. By watching this video, you will be able to answer the definition of shock, classification, stages of shock, then compensatory mechanisms in shock and the management of the shock. First about the definition of the shock. Shock is a term which is used to describe a clinical syndrome in which the tissue perfusion is inadequate due to decrease in the either cardiac output or acute circulatory failure. So, the circulatory shock is defined as a clinical syndrome characterized by inadequate tissue perfusion due to low cardiac output or acute circulatory failure. Next, on the classification of the shock. First type of shock is the hypovolemic shock, and this is mainly due to decrease in the blood volume, which can either occur due to hemorrhage, trauma, surgery, burns, as well as fluid loss due to vomiting and diarrhea producing dehydration. Second type of shock is the distributive shock. Here, the blood volume is normal, but the capacity of the circulation is increased by marked vasodilatation. That is why it is also known as low resistance or vasogenic shock. And the shock coming under this are either due to fainting because of the neurogenic shock, that is marked vagal stimulation, or it can be due to anaphylaxis as well as sepsis. Cardiogenic shock. Cardiogenic shock is because of the inadequate output by a diseased heart, which occur in case of myocardial infarction, congestive heart failure, as well as in arrhythmias. The last type of shock is the obstructive shock, occurring due to obstruction of our blood flow. It can be either due to tension pneumothorax, pulmonary embolism, cardiac tumor, as well as cardiac tamponade. So, next about the stages of the shock. There are three stages for the shock. First one is compensated or non-progressive stage. And if it is not treated adequately, it can progress into progressive stage. And the final or the refractory stage is the irreversible or the refractory stage. So, there are three stages: compensated or non-progressive stage, progressive stage, and irreversible or refractory stage. First, about the compensated or non-progressive stage. Here, the compensatory mechanisms of our body can cause full recovery even without outside therapy if the shock is in compensated or non-progressive stage. But if it have progressed to a progressive stage without therapy, what happens is that the shock becomes steadily worse until the death occurs. And next, about the last stage, that is irreversible or refractory stage. Here, the shock has progressed to such an extent that the patient died despite the vigorous treatment. So, first we will see the hypovolemic shock or the cold shock. The main signs and symptoms of the hypovolemic shock are hypotension, rapid tachypulse, cold and pale skin, oliguria, tachypnea, restlessness, and intense thirst. Now we will see what are the compensatory mechanisms in the hypovolemic or hemorrhagic shock. So, the basic problem in hypovolemic or hemorrhagic shock is the hemorrhage, which can cause a decline in the blood volume, which will decreases the venous return and causing the cardiac output to fall, and this leads to hypotension. So this reduction in the arterial blood pressure initiates certain negative feedback mechanisms that may try to raise our blood pressure back towards the normal. So these mechanisms can be grouped into two, that is rapid compensatory mechanisms as well as long-term compensatory mechanisms. First, we will see what are the rapid compensatory mechanisms which helps to retain our BP back towards normal in hypovolemic or hemorrhagic shock. First one is the activation of the baroreceptor reflex. That is, whenever there is decrease in blood pressure, there occurs decrease in the stretch of the arterial blood pressure, and it causes decrease in the rate of discharge from these baroreceptors, leading to increase in the sympathetic output, resulting in reflex tachycardia and vasoconstriction. And this is responsible for the rapid as well as low volume pulse, which we have seen as the feature of the hypovolemic shock. And this sympathetic stimulation, it can result in generalized vaso and venoconstriction. And the reflex increases the peripheral resistance and minimizes the fall in the arterial pressure caused by reduction in the cardiac output. Here, the arterial pressure should be maintained at above 70 millimeters of mercury or above by sympathetic nervous reflexes in order to protect the blood flow through the coronary and cerebral circulatory systems. So we will see what are the effects of this vasoconstriction in different parts of the body because of this sympathetic nervous reflexes. Vasoconstriction, marked vasoconstriction in the skin accounts for the cold and pale skin. And the intense vasoconstriction in the viscera will shift the blood from the subcutaneous, pulmonary and hepatic circulation into the systemic circulation. So also the contraction of the spleen also discharges more stored blood into the circulation. Now we will see what is the effect of vasoconstriction in the kidneys. In early stages of mild to moderate hemorrhage, constriction of the renal vessels is counteracted by the autoregulatory mechanisms. But with more prolonged and severe hemorrhage, the renal vasoconstriction becomes more intense and the glomerular filtration rate is depressed, leading to decrease in the urine output. So what happens when the urine output is decreased? There will be retention of sodium and nitrogenous products of metabolism in the blood, and this condition, it is known as azotemia or uremia. And when the hypotension is prolonged, this renal tubular damage may be severe, leading to acute renal failure. So, along with the baroreceptor reflex, you are supposed to draw the sino-aortic reflex diagrams, both these diagrams, and these are already explained in the Physio Exam Buddy video that on short-term regulation of blood pressure. The next compensatory mechanism is activated because of the chemoreceptor reflex. The blood flow in the chemoreceptors like aortic as well as carotid body is reduced. The resultant stagnant hypoxia as well as acidosis will cause stimulation of the chemoreceptors. And the increased activity in the chemoreceptor afferents is probably the main cause of respiratory stimulation in shock. This respiratory stimulation and tachypnea will increase the thoracic pumping, which will increase the venous return, cardiac output, and hence the blood pressure. And another action of the chemoreceptors is that it can cause direct stimulation of our vasomotor area and enhances the already existent peripheral vasoconstriction by the baroreceptor reflexes and cause increase in the peripheral resistance as well as cause an increase in the blood pressure. Next is about the CNS ischemic response, how it compensates the in hypovolemic shock. This CNS ischemic response elicits more powerful sympathetic stimulation throughout the body, and it is activated significantly only when the mean arterial pressure falls below 50 millimeters of mercury. Next is about the renin-angiotensin-aldosterone mechanism. Because of the hemorrhage, there will be an increase in the plasma renin activity, which increases the level of circulating angiotensin 2. And this angiotensin 2, it is a potent vasoconstrictor which helps to maintain the blood pressure. And this angiotensin 2 also causes thirst by its action on the subpharyngeal organ. And the ingestion of the fluid helps to restore the ECF volume. The increase in this angiotensin 2 can also increase the aldosterone as well as vasopressin secretion. The decreased firing of our atrial stretch receptors, which are the baroreceptors, also lead to increase in the secretion of this vasopressin. So the increased circulating aldosterone as well as vasopressin causes retention of the sodium and water, which helps to re-expand the blood volume. And the aldosterone usually takes about 30 minutes to exert its effect. Next compensatory mechanism is our capillary fluid shift mechanism. A drop in the capillary pressure takes place because of the decrease in the blood volume. And this causes absorption of the fluid from the interstitial compartment into the circulation. And this helps to maintain the circulating blood volume and thereby restoring the blood pressure. And another compensatory mechanism is the reverse truss relaxation of the circulatory system, which causes the blood vessels to contract around the diminished blood volume so that the blood volume that is available more adequately which fills the circulation. So, next, last mechanism is the catecholamine secretion. The catecholamines, they are epinephrine and norepinephrine, and they are released from the adrenal medulla. This norepinephrine is also derived from the sympathetic noradrenergic nerve endings. These humoral substances from this adrenal medulla, they will reinforce the effect of the sympathetic nervous activity, further increasing the vasoconstriction as well as increase in the heart rate. The increase in the catecholamines may also lead to stimulation of the reticular formation, producing restlessness and apprehension in some patients. And whenever there is restlessness, there occurs increase in the motor activity, which will increase the muscle pumping of the venous blood. And the last two rapid compensatory mechanisms are increased secretion of vasopressin and increase in the secretion of our stress hormone, that is the glucocorticoids. Next, we will move to the what are the long-term compensatory mechanisms occurring in hypovolemic shock. We can divide under three headings, that is there occurs restoration of the blood volume in 12 to 72 hours. Next is the restoration of the plasma proteins which occur in 3 to 4 days, and the final or the last compensatory mechanism to occur is the restoration of the RBC mass, which happens in 4 to 8 weeks. So how the restoration of the plasma volume occurs within 12 to 72 hours. After a moderate hemorrhage, the circulating plasma volume is restored in 12 to 72 hours by absorption of the fluid into the blood capillaries from the interstitial spaces of the body. That is our capillary fluid shift mechanism. And another reason for the restoration of plasma volume is the conservation of both sodium as well as water by the kidneys by the action of angiotensin II, aldosterone as well as ADH. And there will be also an increased thirst which makes the person drink water and increases the ECF volume. Next is the restoration of the plasma proteins which occur in 3 to 4 days. The preformed albumin also enters rapidly from the extravascular stores. After the initial influx of the preformed albumin, the rest of the plasma protein losses are replaced presumably by hepatic synthesis over a period of 3 to 4 days. And the last long-term compensatory mechanism is the restoration of the RBC mass. The erythropoietin will appear in the circulation and the reticulocyte count will increase, reaching a peak in 10 days. And the red cell mass is restored to normal in 4 to 8 weeks. There will be also an increase in the concentration of the 2,3-BPG in the red blood cells, which causes the hemoglobin to give more oxygen to the tissues. So that finishes the compensatory mechanisms in the hypovolemic shock, and we will see what is this refractory shock. Various positive feedback mechanisms can aggravate the hypotension induced by the blood loss and tend to initiate vicious cycles which may lead to death. So, one of the features of the refractory shock is myocardial depression. The hypotension induced by the hemorrhage will reduces the coronary blood flow and therefore depresses the ventricular function. The consequent reduction in the cardiac output leads to a further decline in the arterial blood pressure. Next feature of the refractory shock is vasomotor failure or severe cerebral ischemia. This refractory shock usually leads to depression of this vasomotor area of the brain and causes vasodilatation as well as reduction in the heart rate. These both make the blood pressure drop further with a further reduction in the cerebral blood flow and further depression of the vasomotor and cardiac areas. Next is the blockage of very small blood vessels, which is another feature of the refractory shock. In time, blockage occurs in many of the very small blood vessels in the circulatory system due to sluggish blood flow in the micro vessels. The tissue hypoxia as a result of this becomes worse and anaerobic glycolysis can occur. So, this tissue hypoxia along with anaerobic glycolysis leads to accumulation of the lactic acid, which will increase the local acidity of the blood. So, this acidity plus other deterioration products from the ischemic tissues causes minute blood clots which plugs the small blood vessels. The increased tendency for the blood to stick to one another makes it more difficult for the blood to flow through the microvasculature. Next feature of the refractory shock is increase in the capillary permeability. In the late stages of the prolonged shock, capillary hypoxia and lack of other nutrients gradually increases the capillary permeability. Large quantities of fluid begin to transmit into the tissues, and this will decrease the blood volume even more with a resultant further decrease in the cardiac output, making the shock still more severe. Next feature is the release of toxins by the ischemic tissue. Shock causes tissues to release toxic substances like histamine, serotonin, and tissue enzymes that cause further deterioration of the circulatory system. The diminished blood flow to the intestine often damages the gastrointestinal mucosa, and endotoxins from the bacteria enters the circulation and produce profound vasodilation and cardiac depression. And the last feature is the generalized cellular deterioration. As shock becomes more severe, the metabolic as well as detoxifying functions of the liver are affected, and the activity of the sodium potassium pump is greatly diminished. As a result, the sodium and chloride will accumulate in the cells and potassium is lost from the cells. In addition, the cells will begin to swell. Also, the mitochondrial activity becomes severely depressed. Also, the lysosomes in the cells begin to break open with intracellular release of hydrolases and leading to further deterioration. And cellular metabolism of the nutrients such as glucose eventually becomes greatly depressed, mainly in the last stages of the shock, as some of the hormones involved in the glucose metabolism are depressed, including almost 100% depression of the action of the insulin. So all these effects contribute to further deterioration of many organs of the body, including especially liver, lungs, and heart. Next feature of the refractory shock is acute respiratory distress syndrome, ARDS. This syndrome, it is characterized by acute respiratory failure with high mortality. There is damage to the capillary endothelial cells and alveolar epithelial cells with the release of cytokines. And in mild degrees of shock, the negative feedback mechanisms can easily overcome the positive feedback influences and therefore can cause recovery. But in severe shock, the deteriorative feedback mechanisms become more and more powerful, leading to such rapid deterioration of the circulation that all normal negative feedback systems of the circulatory control acting together cannot return the cardiac output back towards the normal. Now we will see what are the other forms of the hypovolemic shock. First one is the traumatic shock, which develops when the muscle and bone are severely damaged, as seen in battle casualties as well as automobile accidents. So frank bleeding into the injured areas is the principal cause for the shock, and the amount of the blood which can be lost into injury is remarkable, because the thigh muscles can accommodate of about 1 liter of the extravasated blood, for example, with an increase in the diameter of the thigh of only 1 centimeter. Next type of hypovolemic shock is the crush syndrome. Shock accompanied by extensive muscle crushing causes breakdown of the skeletal muscle by rhabdomyolysis. Kidney damage is common in this crush syndrome because in kidneys, glomerular filtration is already reduced by shock, and also accumulation of the myoglobin and other products from the reperfused tissue damage can clog the renal tubules, causing anuria, which can lead to renal failure and can maybe fatal also. Next type of hypovolemic shocks are surgical shock, which is due to a combination of external hemorrhage, bleeding into injured tissues, and dehydration. Next is burn shock. In burn shock, there is loss of plasma as exudate from the burned surfaces. The hypovolemic shock that results from the plasma loss has almost the same characteristic as the shock caused by the hemorrhage, except for one additional complicating factor, that is here the blood viscosity increases greatly. As a result, there will be increase in the hematocrit in the remaining blood, and this causes or exacerbates the sluggishness of the blood flow. Next is dehydration, shock, hypovolemic shock due to dehydration. Excessive loss of fluid from the GIT due to excessive vomiting, diarrhea, or from the skin due to excessive sweating, or due to adrenal insufficiency or diabetic ketoacidosis may lower the blood volume to a degree sufficient to cause hypovolemic shock. So, we finishes what are the compensatory mechanisms and what are the different types of hypovolemic shock. Now we are moving on to the second type of shock, that is the distributive shock. Here, the blood volume is normal, but the capacity of the circulation is increased by marked vasodilatation. It is also called as warm shock because here the skin is not cold or clammy as in hypovolemic shock. And the causes for the distributive shock are either anaphylaxis, sepsis, or fainting or neurogenic shock. First, we will see what is this anaphylactic shock. A rapidly developing severe allergic reaction that sometimes occurs when an individual who has previously been sensitized to an antigen and is re-exposed to it. And the resultant antigen antibody reaction will cause the release of large quantity of the histamine, which causes increase in the capillary permeability along with widespread dilatation of the arterioles and capillaries. Next is the septic shock. Infections mainly by the gram-negative bacteria causes shock which has both distributive and hypovolemic features. And these endotoxins, they are cell wall liposaccharides produced by some bacteria, causes vasodilatation and increased capillary permeability along with loss of plasma in the tissues. This will also initiate a complex series of cytokine and coagulant reactions that can lead eventually to multi-organ failure. And the special features of the septic shock are high fever, marked vasodilatation. That is why it causes warm and dry skin instead of the cold and clammy skin. Then there is sludging of the blood. There will be disseminated intravascular coagulation, that is development of the micro blood clots in widespread areas of the body. And also this causes the blood clotting factors to be used up, leading to bleeding from many tissues, especially from the gut wall of the intestinal tract. Increased permeability of the pulmonary capillaries can lead to pulmonary edema, ARDS, and respiratory failure. Diminished renal blood flow leads to tubular necrosis and renal failure. Next type of this distributive shock is fainting or neurogenic shock. Here, there occurs a sudden burst of the autonomic activity because of the sympathetic cholinergic vasodilator system as well as the cardioinhibitory center, and it produces vasodilatation and pooling of the blood in the extremities leading to fainting. And these are called vasovagal attacks and they are short-lived as well as benign. Next is about the cardiogenic shock, when the pumping action of the heart is impaired to a point that the blood flow to the tissues is no longer adequate to meet the resting metabolic demand. This condition, it is known as the cardiogenic shock, and it is most commonly due to extensive infarction of the left ventricle, but it can also caused by other diseases that severely compromise the ventricular function. The symptoms are those of shock plus congestion of the lungs as well as viscera. Obstructive shock, it is mainly due to obstruction to the blood flow. When the obstruction is due to tension pneumothorax with kinking of the great veins or bleeding in the pericardium with external pressure on the heart as in cardiac tamponade, prompt surgical intervention is required to prevent death. And finally, about the treatment of the shock, it should be aimed at correcting the cause and helping the physiological compensatory mechanisms to restore an adequate level of tissue perfusion. So, in hemorrhagic, traumatic and surgical shock, the primary cause of the shock is blood loss. And the treatment should include early and rapid transfusion of adequate amount of compatible whole blood. In hemorrhagic and neurogenic shock, even the foot end elevation causes an increase in venous return can also help. In neurogenic shock, sympathomimetic drugs like epinephrine as well as norepinephrine causes constriction of the dilated vessels. In burns, the problem is hemoconcentration. The plasma is the treatment of the choice to restore the fundamental defect, that is the loss of plasma. So plasma expanders, which are the solutions of sugars of high molecular weight and related substances that do not cross the capillary walls, have some merit. Out of this, the concentrated human serum albumin as well as other hypotonic solutions like dextran, they will expand the blood volume by drawing the fluid out of the interstitial spaces. In dehydration due to vomiting and diarrhea, 0.9% normal saline is found to be useful. And in case of anaphylactic shock due to allergies, injection of the adrenaline can cause constriction of the dilated vessels, as well as glucocorticoids can decrease the reaction, antigen antibody reaction. And in septic shock, we have to give the antibiotics. In cardiogenic shock, digitalis is found to be useful. And in obstructive shock, prompt surgical intervention is needed to correct the obstruction. Thank you for your patient listening and keep on watching Physio Exam Buddy, which makes your physiology exams more easier.